specific physical signs, but so it will help us, but if they have the long term asthma, they can have this barrel shaped chest and Harrison's occur because of this chronic asthma. Other than that, so we can find some examination findings related to other contributing conditions like atopy, some eczema and polyposis. So other than that, no other specific features of asthma, right? So, so with these symptoms, the variable expiratory airflow, so these they have the expiratory airflows with the expiration, they have limitation. So we have to find whether it is variable. So variable in the sense during the exacerbation, morning, night. So how are we going to so objectively say this child is having this expiratory limitation? So developed countries, they have these the proper documentation and proper tests. Since we have some limitations, so we don't do so routinely these tests, and but this device is called peak expiratory flow meter. It's just a handheld device. We ask and we need to ensure that he didn't take these short acting relievers for 4 hours. If it is long acting reliever for 24 hours, we need to just ensure that, and then ask to take a deep breath with for the full expiration, and we just measures, and there is such, and also and then give the salmeterol inhaler or nebulizer, wait for 10 to 15 minutes and redo that. So if there is a response, there will be a good there will be an increase in this expiratory flow, right? There will be a change. If there is a change is more than 12% and it is positive, so this child is having variable expiratory airflow. This is one of the method. It is very easy to do, but for the practical we don't do, but still we do the bronchodilator reversibility. So bronchodilator reversibility, so we, other than doing this peak airflow meter, we do with the nebulizer thing, and then we listen to the chest later. We don't do objectively, but it's good to know there are lots of methods to measure these variable expiratory airflow limitation. Yeah. Right. So this is again the flow chart. So saying so how do we diagnose the asthma? So based on the GNR 2025. So basically any child with the recurrent respiratory symptoms or chronic respiratory symptoms, we always detail history and examination. So if it is suggestive, and then if we have spirometry, spirometry is the one, is another lung pulmonary function test. If it is available, we can do that. If not, then we can do this bronchodilator reversibility and then diagnose. So meantime, before we diagnose asthma, still we have to consider some differential diagnosis as well, depends on the symptoms. So if the child is coming with a chronic upper symptoms, kind of like sneezing, itching, kind of blocked nose, sometimes when we listen to the chest, so it may like mimic case of wheeze, bronchi, but basically it's a kind of like upper airway transmitted sounds. So we have to with a good history and examination, so we have to clinically define whether it is a upper airway cough syndrome. And so say if the child coming with the sudden onset unilateral wheeze, always we have to keep in mind, so whether there is a inhaled foreign body, so if it is a unilateral wheeze, right? So asthma is always a kind of like dry cough, unless dry cough. If the child is the recurrent infection and chesty cough or productive cough, so that is against the asthma. So we have to think of chronic lung disease or bronchiectasis or other primary congenital immunodeficiencies, right? And so with related to chronic lung disease could be there are could be a ciliary dyskinesia, if the child is preterm and coming with a recurrent chest symptoms since birth, and then so that be a underlying bronchopulmonary dysplasia. So if the child is coming with a distress, and so mainly young infants, so presents with the ED with a kind of like respiratory distress, is not always the bronchiolitis or wheeze, right? So actively we have to look for whether there is any murmurs, because maybe the undiagnosed heart disease coming with the heart failure. So always we have to think of differential diagnosis, mainly in infants coming with a respiratory distress. So we actively look for any features of heart failure, listen to the heart sounds, any murmurs, any cyanosis, any tender hepatomegaly. So of course they will have the bilateral crackles. So always, so we have to keep in our mind the heart failure, especially in infants when they present with the respiratory distress. Yeah. And so again with the history, any contact history, TB and PART3, these are the differential diagnoses. So as apart from this diagnosis test, this is the one that I told earlier, the pulmonary function test. And so chest X-ray, we don't do chest X-ray to diagnose asthma, but if they present with a severe exacerbation or life threatening, just or not responding to our routine the management, emergency management, to rule out any other thing, so kind of like any pneumothorax or any other associated condition, we do chest X-ray. But asthma itself, it can cause this hyperinflation and narrow mediastinum. And so other thing is the allergy. So sometimes so we say it could regarding the allergies. So main like parents worry. So this child is this food triggers this asthma, whether to avoid. So only thing is regarding allergy and asthma, it's so we have to we should confirm this food or this food is causing this exacerbation, or we always should confirm, or by allergy testing, that this is the trigger for him. Always we should have the allergy testing to confirm whether this child has this allergen is causing sensitized. If it is sensitized only, we have to ask to avoid. Otherwise, say if they can think so different food, if they think and just avoid, ultimately it will lead to the growth failure and failure to thrive. But otherwise, so in other case, so if it is confirmed, and then we can avoid. Without confirming, we can't advise the parents to avoid those food. So we should have always a confirmatory allergy testing to say whether he is allergic or not. So we can't randomly say to avoid this. Yeah. So we have wide so variable skin prick testing, and also we can measure the IgE level. So if there is allergen specific IgE levels are available, so we can do those things. And so good to know about this one is the so we have the so airway inflammation or asthma based on this pathophysiology. So now we can do this fractional concentration of exhaled nitric oxide. So this is the newer investigation. It's available in so LRH, available at LRH. So basically, if the drug resistant asthma, sometimes we go up to the stepwise management, we go up to step 3, step 4, still child is having, it's not poorly controlled or it's not controlling well, and then we have to define whether why it's not, then it's not allergic asthma, then if there is anything else that we can do, right? So in that case, so on special circumstances, we can measure these this nitric oxide, it's in the we have the bronchial epithelium, so when they get inflamed, so this because of these nitric oxide synthase enzymes, so it exhale, because of the damage they will exhale more nitric oxide. So if there is to confirm this airway inflammation, so we can measure this fractional exhaled nitric oxide, and also they'll have the blood eosinophilia anyway. So because of type 2 asthma, because it is this investigation and management is now well developed, and so they can have these biologics. So there are different type of biologics apart from these steroids and inhalers. So so if they have those things, then we can prescribe. So so we need to get the specialist advice to start those biologics.